Enhanced recovery after surgery, multimodal pain medication. How to implement a multimodal pain medication for postoperative pain to decrease opioid medication at discharge. Today I will discuss implementing a multimodal pain regimen to treat pain for patients undergoing general surgery. One of the things that we have learned over the years is that the use of opioid is associated with higher complication rate after surgery and higher chance of long-term opioid dependence. The multimodal pain medication has helped reduce opioid use after surgery. Here we highlight a method of implementing this program. The program starts at the very first visit with the patient. When we see patients in clinic, we first determine if the patient is opioid naive. The program does not work for patients who are on chronic opioid medication. Next, we discuss the expectation of pain after surgery. For example, for patients who are undergoing laparoscopic hiatal hernia repair, we tell patients that most patients do not have lots of pain in the incision, but they have pain in the shoulders. The shoulder pain is from insufflation and will go away in 2 days after surgery. By explaining this to the patient, when they wake up from surgery, they do not panic. We also tell them that we'll write for a standing multimodal pain medication to help with the pain. Another important message that we want to tell the patient is that the goal of the pain medication is to keep the pain manageable and not to be completely pain-free. This sets their expectation after surgery. In the clinic, we write for preoperative medication of gabapentin 300 milligrams and tramadol 50 milligrams to be given right before surgery. On the day of surgery, in the pre-op, patient receives gabapentin and tramadol. During surgery, we give 1 gram of IV Tylenol at the beginning of the case. We also give Exparel at the preperitoneal space and the port site. We use 5 ports for the robot-assisted laparoscopic hiatal hernia repair. Thus, we put 4 cc's of Exparel in each incision. We have found that putting the Exparel in the skin does not significantly impact the patient, but placing it in the prepared space really helps. The anesthesiologist minimizes the use of opioid during the case. After surgery, one of the key things that we found for the patient is to give around-the-clock pain medication. So we write for these medications as a standing order. We write for patient to receive 1 gram of Tylenol every 8 hours, 500 milligrams of Robaxin every 6 hours, and 15 milligrams Toradol every 6 hours for 3 days. Toradol is prescribed only if patient has no renal issues and no concern for bleeding after surgery. We also write for Lidocaine patch as needed and 300 milligrams of gabapentin every 8 hours as needed. Finally, we write for 50 milligrams of tramadol as needed. We tell the patient to ask for Lidocaine patch and gabapentin if other medications are not enough, and if that does not work for them, ask for the tramadol. At the time of discharge, the standing discharge pain medication is 1 gram of Tylenol every 8 hours for 5 days and 220 milligrams of Aleve every 12 hours for 3 days, only as long as they do not have any renal issues and no concern for bleeding. Now, at the time of discharge, patients seem to have more pain than expected. Then we give a script for Robaxin and then ask them to only take it if Tylenol and Aleve do not work. If patients seem to have need something more in terms of pain medication, we give them a script for 300 milligrams of Neurontin every 8 hours. We write 14-day script for Robaxin and Neurontin. There are a couple of things you should consider when using these medications. For elderly patients who are 75 years and older, we usually stay away from gabapentin or use it at lower dose of 100 milligrams every 8 hours. Most patients tolerate gabapentin well, but few patients have side effects from the medication. The most common side effect is dizziness and headache. If they develop them, we stop the drug. And usually the symptoms resolve within 24 hours. If patients have very low BMI, we start at a lower dose of gabapentin dose. If patients have renal insufficiency, we start at a lower gabapentin dose and no Toradol or NSAIDs. And if patients on anticoagulation, we do not use Toradol or NSAIDs. The biggest concern that I had with this program when we tried to implement it in our office was that I was worried that by not giving an opioid script, we would get lots of phone calls asking for pain medication. We did not get any phone calls from this group of patients. However, if this is a barrier to implementing this program, consider giving a script for tramadol and all the other multimodal pain medication. Ask the patients only to fill the tramadol script if all of the other medications do not work. When you see them in follow-up, and ask them if they fill the tramadol. If your patients are not filling the tramadol script, then consider stop prescribing it. In our practice, we found that patients did not need opioids after laparoscopic surgery. The successful implementation of multimodal regimen in our practice has led to a significant decrease in opioid prescription from 87% to 9.6%. In conclusion, multimodal pain medication will decrease number of opioid use after surgery, reduce complication, and decrease opioid dependence. Thank you.